Today we're going to discuss the new recommendations from the American College of Physicians, that's the ACP, on pharmacologic treatment of episodic migraine headaches. Episodic migraine headaches are headaches that occur 1 to 14 days a month. This is an important area for those of us in primary care because we see patients with migraines frequently. About 1 out of 6 adults in the United States have migraine headaches, and some of the recommendations for treatment have changed over the last few years. I'm going to go over the recommendations from the ACP guidelines, but I'll also point out an area where that recommendation is different than other recent recommendations by the American Headache Society that I've also discussed. I'll also add some clinical pointers at the end, and also I'll mention some medications and supplements that aren't directly addressed in the guidelines. First, it's important to realize that when we make a decision about starting something for prevention of migraines, there is not a strict cutoff that is mentioned in the guidelines, but rather that decision is a matter of clinical judgment and ought to be a product of shared decision-making between us and our patient. Some people get headaches once or twice a month. They take an acute reliever medicine, it works, and then they go on their way. They don't need preventive therapy. Other people may have more frequent headaches or more severe headaches that interfere with function or that don't resolve very easily. The degree of discomfort, the efficacy or lack thereof of reliever medications, the interference with function and personal goals all influence a patient's desire to prevent headaches and determine together in a discussion between us and the patient whether to prescribe preventive therapy. The ACP guidelines recommend the following first-line options for preventive therapy. 1, a beta blocker, either metoprolol or propranolol. 2, valproate, which is an anti-seizure medicine. 3, venlafaxine, that's an SNRI. Or 4, amitriptyline, a tricyclic antidepressant. All of them have equal efficacy. All of them are recommended as first-line agents. They have differing side effects. We make a decision based on discussion and the personal needs of the patient, also with attention to side effects. For second-line treatment, the ACP statement suggests that the CGRP antagonist GPANT or a CGRP monoclonal antibody be considered in patients who do not tolerate or who inadequately respond to one or more trials of the first-line agents that I just mentioned. Now, in a previous column, I discussed the American Headache Society's position statement recommending that CGRP targeting therapies should be considered a first-line option in addition to the other medicines mentioned for prevention of migraine headaches. So this is a little bit different than the ACP guideline. The American Headache Society's rationale was valid and solid. And what they talked about was that CGRP therapies are well tolerated, they are safe, and they are as or more effective than traditional first-line agents. Because they are migraine-specific agents, they have less off-target effects than some of the traditional first-line agents. Here's the hitch, though. They're considerably more expensive, up to 15-fold more expensive, and that is the reason that the ACP has recommended them as second-line, not first-line agents. That also makes a lot of sense. Topiramate, which used to be a first-line agent, is now only recommended in the ACP guidelines if someone does not respond adequately to both first-line agents and a CGRP targeting therapy. The main reason for that is that topiramate often has undesirable side effects, particularly cognitive side effects, and there is some evidence that suggests that it's not as effective as the other agents. Also discussed in the ACP guideline, but not emphasized due to less robust available evidence, are the ACE inhibitor lisinopril, ARBs, candesartan and telmisartan, and the SSRI fluoxetine. You'll notice calcium channel blockers have dropped off the list. Riboflavin, feverfew, butterbur, coenzyme Q10 and magnesium are not mentioned in the ACP guideline, but have been discussed in the medical letter, see the link below, and in the American Headache Society, American Academy of Neurology guidelines, also see the link below, as having good efficacy with varying strengths of evidence. Remember, when we talk about migraine prevention, lifestyle is also important. Explore with the patient whether there are triggers that can be avoided, and also emphasize adequate hydration, sleep, and physical activity. Recognize that CBT has also been shown to have some evidence. From a practical point of view, when we prescribe a medication for prevention, it's important to let patients know that the preventive medicine can take up to a few weeks to kick in. And if there's not an adequate response by 2 to 3 months, then a different preventive medicine can be tried. An important question that is frequently asked is whether other medicines in the same class as those specifically mentioned as first-line treatments by ACP may be used for migraine prevention. For instance, can you use the SNRI duloxetine or the TCA nortriptyline, even though only the SNRI venlafaxine or the TCA amitriptyline is mentioned in the guidelines? That question isn't addressed in the guidelines. I'm going to say that is usually fine. There was a medical letter, again, linked below, that discussed this and supports that statement. This is an important update, and it provides really nice, honed, clear, straightforward information that allows us to treat migraine headaches with confidence, and it's something that comes up a lot. I'm interested in your thoughts and your experience treating migraines. Please leave your comments in the section below. For Medscape, I'm Dr. Neil Skolnik.